Hi, I'm Dr. Joe Pellerin, and I'm going to be showing a procedure which I do frequently, treatment of a deep caries lesion, a caries exposure with direct composite restoration. In this case, I'd like to first show how I give anesthesia. It's very, very comfortable for the patient. What I do after placing the topical anesthetic, and I get that in there liberally, is to take my local anesthetic, in this case 4% Septicaine with epi 1 to 200,000, and I like to warm that, get it up to body temperature. I like to give a little bend to my needle. This is a 30 gauge short, and that allows me to get a better angle for perforation of the tissue. Now I'm going to take the tissue, the lip, I'm going to stretch that very aggressively, and I'm going to pull it over just the bevel of my 30 gauge. Now, just a drop every few seconds initially. And it could take me 60 or more seconds to place this. But by the time I'm through, the patient will have felt next to nothing. Now, Connie, how was that? Have you ever had anything like that?
Never felt a thing.
Once I've achieved good anesthesia, I'm going to open this lesion from the lingual with a high-speed number 35 inverted cone. I'm going to strip that enamel shell so that I can expose the full extent of the caries that's invading the dentin. And then I'm going to go into the dentin with a slow speed, number 4 round, and I'm going to extirpate the caries very, very carefully. By the time I'm done, we're going to see that we have a virtual exposure. And if you can do this very carefully, as I have here, we're not going to have any hemorrhage, but we're going to have what I call a window exposure. You're going to see the pulpal chamber. Once I've thoroughly removed the caries, I'm going to take a tapered diamond and I'm going to bevel over the buccal aspect of the lesion, 2-3 millimeters out from the edge of the lesion. And when we finish, we're going to wrap the composite around here so that we don't have a half-moon effect, that this whole thing blends in. Now, as we restore this lesion, we're going to be using a total etch technique. I'm going to use some 40% phosphoric acid from Ultradent for 15 seconds. After I rinse that off, I'm going to come in with some Hemaseal Cide. And this product is what really makes the procedure a high percentage for me. I used to do this before with about a 60% success, and now I'm 90% or better. You're going to disinfect and help to get a better bond and less micro leakage with the Hemaseal Cide. I use it under my final cementation, under my temporaries, virtually under everything I do. But here, it's going to be great because it will help the bond with both self-etch and total etch products and allow me the great success with this type of lesion. I come in, wet it with the Hemaseal Cide, wick away the excess with a microbrush, leaving it moist but not puddled. And here I'm going to use some Ultradent PQ1. I'm going to come over the exposure and the entire lesion, buccal and lingual, and I'm going to air thin that. We're going to cure it, and I'm going to come in with a second coat and cure that again. Then I'm going to come in with a product from Tokiyama called Ilic. That is a flowable composite. I like an A3. And I'm going to put a couple coats in here to build up my dentin aspect of the tooth. Once we have that cured, we're going to place a mylar strip, and I'm going to take some, again, a Tokiyama product, Ilic A2, and has a great chameleon-like effect. We're going to come from the lingual, push it through, wrap it around with a mylar strip, and cure it. Once I've cured the restoration, I'm going to remove the mylar. I'm taking a fluted carbide. I'm contouring buccal and lingual, make sure my occlusion is good, and that this fades or blends into the buccal aspect of the tooth with no edges. And after I've done my work with my fluted carbide, I'm going to take a self-disintegrating rubber cup and a little diamond polishing paste, and I'm going to finish that lesion. And you can see that we're going to get a great result here. I know this procedure, this technique may be frightening to a lot of dentists, especially etching over virtually exposed pulpal tissue. So if that does frighten you, instead you can go with a glass ionomer, something like Vitrabond from 3M. And as long as you get the Hemaseal Cide underneath it, leave it slightly moist, 1 or 2 layers of Vitrabond, then you can etch Hemaseal Cide again, bonding agent, and build up. It works very well that way. I just have great success with the direct composite.